Then welcome to Jodi Allen. It's in her slide already, senior speech and language therapist in neurology and neuromuscular disease. As we all know, part of the difficulties with in Duchenne could be the swallowing difficulties. And we are so happy that you are here today to present on that subject. Thank you so much, Jodi.
Thank you, Elizabeth, and thank you, Anton. I'm going to take you on a journey back up the gastrointestinal tract now into the throat and the mouth and talk to you about the management and assessment of swallowing difficulties in Duchenne. So just to recap, this is an area that speech and language therapists are very familiar with, and yet our job title is very misleading because it doesn't include the term swallowing in our job title. So some people do feel quite confused when they get referred to a speech and language therapist for swallowing. So a short overview of the swallowing system. We divide it very crudely into three areas. So the pre-oral phase, so that's the phase of getting the drink and the food from the plate or the cup into the mouth. The oral phase, so that's the phase of swallowing associated with chewing and moving food around the mouth. And then the pharyngeal phase, which is the throat phase, as food moves through the throat into the esophagus, into the food pipe towards the stomach, which is where Anton has just taken us on a journey. So we use the term dysphagia to describe a disorder of swallowing. And on the left here, you can see an X-ray of swallowing, and somebody is swallowing there something liquid that comes up black on the X-ray. And this is how we study swallowing in speech and language therapy, or one of the ways in which we study swallowing. So the first thing I'd like to talk to you about are some of the causes of dysphagia or swallowing difficulties in Duchenne. Now, most of what we know about swallowing difficulties in this area is associated with weakness, so weakness of the mouth and the throat muscles. It can also be associated with weakness in the respiratory system because the throat has two functions. It can function as an airway or a foodway, and if your throat muscles are being used for your breathing and you have struggles with your breathing and respiratory weakness, it can impact your swallowing too. What we also know about Duchenne is that young men with Duchenne might have jaw contractures, they might have an enlarged tongue, or they might have malocclusion, so a misaligned jaw, and that can contribute to swallowing difficulties. It can also contribute to issues with drooling, especially if people can't close their mouths sufficiently and saliva comes out the front rather than down the back to be swallowed. One thing we haven't studied in any great detail are sensory deficits in Duchenne muscular dystrophy, but what we do know by looking at some of the swallowing studies in this group of people is that people with Duchenne can have silent aspiration, and that means food and drink can go down the wrong way without us knowing about it, and the first sign of it going down the wrong way might be a chest infection. In a number of people with Duchenne, often it's a combination or more than one of the above, and it's our job as speech and language therapists to try and understand what the causes are. And one of the bigger challenges, and very importantly in Duchenne, is that we're not just dealing with an isolated swallowing problem. That swallowing problem belongs to somebody who may also have problems with moving food to the mouth. They may have problems with their posture and their breathing. They may have problems with appetite or their bowels, and they may have problems with breathing and coughing. So it's more complicated than just dealing with the swallowing difficulty itself. And because it's complicated, the impact of swallowing difficulties can be quite significant. So two of the biggest impacts are maybe weight loss, as Dr. Emmanuel has already mentioned, perhaps dehydration and loss of calories. And if you lose calories, that reduces muscle mass, muscle integrity, and that in turn can then impact the swallowing further. And as I mentioned, if the swallowing is not so good, food and drink might go down the wrong way, and it might cause unexpected chest infections or hospital admissions with pneumonia. And what we do as speech and language therapists is try to reduce the risks of both of these. So there has been quite a shift in thinking, particularly as Ros Quinlivan said at the start of this conference, that people with Duchenne are living a lot longer now, thanks to lots of medical treatments and respiratory interventions. So as speech and language therapists working with more of an adult group now, we've had to jump up and step up and think more carefully about identifying swallowing problems that perhaps weren't always an anticipated or expected part of the disease in childhood. So they weren't previously considered too pivotal in Duchenne, but now we're recognising that there is an increased prevalence of swallowing problems, and the severity of the swallowing problems is perhaps likely to increase as life expectancy increases. So we've started to shift away from the early guidance, which was produced in 2010, whereby Anton has already covered these, whereby we look for any markers that might suggest swallowing difficulties. So such markers might have been unintentional weight loss, so more than 10%, long meal times, spilling, drooling, food pocketing in the mouth, coughing, choking, or aspiration pneumonia. And as far as I'm concerned, these identifying swallowing difficulties at this stage is almost too late, because some of the problems have already occurred. So our shift in thinking is now about identifying the issues much earlier on to prevent the weight loss, to prevent the chest infections. And that relies on a really good relationship between the speech and language therapist, the patient and the clinical teams to look hard for swallowing difficulties. So we take a much more anticipatory approach. We assess swallowing function earlier on, sometimes in the ambulatory phase. We try to repeat it, or we aim to repeat it every 6 to 12 months. We ask sensitive screening questions, and we often talk early about our patients' views on gastrostomy and feeding tubes. The question is, how do we get in early and how do we identify the problems? Well, there's no particular tool that works in Duchenne muscular dystrophy that we know is really sensitive for picking up these problems. We like self-report tools. We like tools that patients can use to tell us what's happening because they're very accessible and people can use them out in their homes and in the community. However, we don't know how good they are. In our hospital and in medi-centres, instrumentation is the gold standard, but it can be quite inaccessible to people with Duchenne because they're often based in hospitals. Some of the clinical questions that we recommend to screen for early swallowing problems include chewing difficulties, any issues with clearing the mouth or leaving food in the mouth, slowed eating, and a meal time that's longer than the meal time that perhaps your partner, your sibling, your parents have. You might be using drinks with your meals to try and clear food down. You might experience hard or effortful swallowing, or feel a general inability to swallow or get the swallow going. Food catching in the throat, and it might just be specific foods, or needing to swallow more than once to get the food from the throat into the food pipe, or coughing, choking and throat clearing. And these recommendations have come from a currently unpublished systematic review. And some more holistic markers based on clinical experience and the literature that might indicate somebody is at more risk of swallowing problems is if a patient has they've lost their independence with feeding, they're relying on others perhaps to bring the food to their mouths. There's been a decline in respiratory function, and there has been a recent paper that links respiratory function with changes in swallowing and eating. And other markers that we've seen on our unit are patients perhaps using their NIV more regularly or using cough assist before, during or immediately after meals to clear food. In terms of instrumentation, we do quite like using the instrumentation, the X-ray that you can see on the bottom of the screen just here, or perhaps a camera. It helps us understand the problem and tailor the management as well as we can, and it allows our patients to see exactly what's going wrong with their swallowing and how to manage it as good as we can. It can also detect any sensory changes that we're unaware of. Ultimately, these tests can be quite time consuming. They might need to come to the hospital. So we do need to ask as clinicians whether it will ultimately change what we do. Here's an image of two of the instrumental techniques that we might use to look at swallowing. And I've just outlined here in red areas where we can see food collecting a little bit on the X-ray and a little bit of food collecting in the throat with the camera. And they're the sorts of things that we might identify in patients living with Duchenne. So what's our management? So speech and language swallowing management in the first line should consider compensation. So that means food adaptation or cutting certain foods from the diet that cause problems. Perhaps it's adding extra sauces or gravies to meals. Perhaps it's having an extra drink when you're eating and drinking to wash things through. There's not a really strong evidence base, but we know an awful lot of patients report on using these techniques to manage their swallowing. And some of what we do know is based on the fact that there is underlying muscle weakness, and therefore things that don't need chewing as much tend not to cause so much of a problem. There's a very small body of evidence to suggest that skill training might be helpful in Duchenne. It's a very small evidence, and the actual exercise that was targeted was chewing strength. And the program actually the research was conducted by colleagues in the Netherlands, and they showed that by chewing gum, it didn't necessarily improve strength, but it improved chewing skill for people with Duchenne. Again, I think it needs careful tailoring and management because chewing gum can be quite high risk for certain patient groups. The other thing that we definitely address in our centre and we recommend is making sure that respiratory management is really well managed, because if the respiratory system is well managed and refined, it takes a lot less pressure off the swallowing system. And what if first line management doesn't work? Well, then we look towards enteral feeding. So if we're struggling to maintain weight, we're struggling to prevent chest infections, people are losing their enjoyment in food and drink, we might think about things like a gastrostomy. And these sorts of things are offered with full MDT support, advice and dietetic input. And often the placement of these tubes are dependent on the respiratory function, cardiac function and BMI. So it takes a skilled, knowledgeable team to support these patients through the pathway. And it goes without saying really that one size doesn't fit all when it comes to swallowing in Duchenne muscular dystrophy. You can see from a range here of patients that some people at a young age are requiring feeding tubes to support their swallowing and their nutrition, and yet we have patients in our service who are older and they have managed to continue eating and drinking by mouth, optimise their swallowing and not need a gastrostomy. So it is about individual management and assessment. What do we suggest in terms of routine monitoring? Well, we like to use a self-report tool. In our service, we use something called the Sydney Swallow Questionnaire to measure incremental changes over time. We conduct reassessments in various functions, respiratory, cough, mobility function, all of those things you've heard about this afternoon already. And we look hard for changes in swallowing because they are often subtle. And the question, have there been any changes to your swallowing, is often not sensitive enough to pick up those changes. So we need to make sure our questions are right. And if we need to, we repeat our instrumentation. We use things like X-ray and cameras if we think it will help our management. So in terms of swallowing advice, our first recommendation and our information to patients and their families is that swallowing changes are very slow. It's really helpful to reflect back about 12 months to assess for any change. So the question, Think back to last Christmas or to a pertinent event that was maybe 12 months ago in your calendar, and think about your dinner at that point. How does that look different to the dinner that you eat now? If you notice differences there, then perhaps there are some incremental changes in the swallowing. And we make general advice like taking time to chew food down well, avoid or adapt tricky foods, consider moving towards blended or liquid foods, and that's often something people do independently without the advice of a speech and language therapist. Taking small regular sips of fluids when eating to help clear the throat. It doesn't work for everybody, but it can work. Avoid talking whilst eating, because the throat has two functions, like I said. One's for talking and breathing, one's for eating and swallowing, and it doesn't like doing both at the same time. Try to get your posture right during and after your meal, and give yourself plenty of time. And of course, it's important to instruct the people helping you in how best to support your eating and drinking. Don't assume that everybody knows how you like to eat and drink. And we do try to reiterate that the advice of the respiratory therapy team is really important, because ultimately they're managing the patient's breathing. And if anything does go down the wrong way and it leads to a chest infection, then we need to make sure that our respiratory physiotherapists have put in place chest management programs, much like Charlotte was talking about earlier. So in summary, swallowing care should be proactive, preventative, and multidisciplinary. It should guard against malnutrition and preventable hospital admissions with pneumonia. It should be realistic. It should promote independence and quality of life, and should be centred around patient choice with full support of a skilled multidisciplinary team. And I will say thank you very much for listening at this point, and there are my contact details.